first. Now we're gonna go live on Facebook. You guys just hang in there. I have, I think, 51 windows open today on my computer. Let's do it again. It didn't work. Here we go. Page. Go live. Hello, hello. Welcome, everybody. Happy Thursday. We are here with Elizabeth Dewar-Anthony. We're so happy to have her on Airway Circle today. This is our Thursday night live. We welcome everyone to watch from either Facebook or in our Zoom. We have a really good frequency going on and really good community going on Zoom over here with our chat. But we welcome everybody to share this with your colleagues, share on your professional page or personal page. It's going to be available live only, and then it goes into our membership. I am going to let Angela do the honors and introduce our guest today.
Wonderful. Thank you so much, Renata. Beth has been a clinical dental hygienist for over 30 years. She has experience working in general practice, periodontics, pedodontics, and nursing homes. She has observed how dental fear creates a downward spiral of reactions for patients and practitioners. Her education in myofunctional therapy helped her realize dental fear is based on the inability to breathe. Many troublesome patient behaviors arise from a compromised airway. Beth is a passionate advocate for changing the way practitioners approach difficult patients so that everyone has a better experience. She has created a live interactive webinar with the same title as this presentation that includes information on self-care for dental professionals along with a guided meditation. As an experienced singer and actress, she is able to make her presentations memorable while allowing her audience to leave feeling uplifted. Oh my God. Beth is a certified specialist in orofacial myology, an experienced speaker, published writer, and the author of Surdentity. She is the CEO of Denta Diva, that was a tongue twister, in upstate New York. Beth, we're so honored to have you here tonight on Airway Circle with us. The floor is yours.
Hi. Oh my gosh. When I wrote that, I didn't think anybody's going to read it out loud. I'm like mortified now. I'm like, oh, it sounds like I'm like a big deal. Oh my God. Now I have to do a good job.
Girl, you are a big deal. You're on Airway Circle.
So, yeah. Hi, everybody. It's so awesome to be here. And I recognized a lot of names from interactions in the Facebook groups. So it's really cool to be here and to share some of my knowledge with you. Like Angela was saying, so I've been a hygienist for 35 years actually, and I have been interested in and really concerned about patient dental fear and how it affects patient behaviors since 1995 was when I very first started. So I've been at this a long time. But when I took the myofunctional therapy course, like within 15 minutes of the first day, I was like, oh my God, it's because they can't breathe. What? And that was even after I published the book Surdentity. I need to republish it with my new information because with all that was in that book, it's only half of what I know now. So I'm just really, really grateful to be here. And I love listening to myself talk. So it's win-win. So let me share my screen. I kind of pared this down a little bit. Come on now.
Need help?
Apparently. Come on, what's up with this
It's
thing?
all good.
There we go.
Take your time.
Do you see it?
Not yet.
Nope. So click on the bottom where it says share screen in green.
Share screen. There we go.
And then it's going to give you an option to choose which screen do you want to share. You can pick the presentation only.
Oh, it's coming. Yay.
Yay!
Good job.
All right, woohoo! All right, so airway and patient behaviors, the roots of dental trauma. I also added the word anxiety because one dentist, when I gave this in for the Buffalo, University of Buffalo CE, he thought it was about like getting your tooth knocked out. Dental trauma. So, I mean, he ended up enjoying the course anyway, but it was not what he was expecting. All right, so first things first, intentions and outcome. Oh, you know, we don't intend to create negative experiences for our dental patients, okay? It's not like we're sitting in the morning huddle and it's like, okay, Beth, I want you to traumatize Mrs. Jones over here. Karen, I need you to slice off Mr. Smith's papilla, and I'm gonna break Mr. Jones's maxillary tuberosity, okay? Got it? Let's go. You know, we don't plan these things, okay? And we all have good intentions. We are all good people. But you don't have to, you know, one doesn't have to operate with great malice to do great harm. And I really think it's the absence of understanding that is the problem. And increased understanding brings increased empathy. And if I have to teach you what empathy is, you are in the wrong career, people. So today, my goals, I want to help you increase your understanding, and I want to help everybody increase their serenity. So serenity, you know, serenity is a feeling of peacefulness and calm. So we are healthcare providers. Okay, let's give it up for ourselves. We are healthcare providers, and if you know, if we want to be taken seriously as healthcare providers, it's important for us to understand. And I know I'm preaching to the choir here, but to understand the connection between the brain, the body, and the oral cavity. The mouth, you know, the mouth is linked to the bloodstream even when gingiva is healthy. Okay, I'm probing these people 2 to 3 millimeters is oh great, yay. But guess what? 2 to 3 millimeters is like Cleveland for bacteria. Okay, there's plenty of space in the average sulcus for bacteria to collect and proliferate. My personal theory is that in early humans, this was a survival trait. The mouth was connected directly to the bloodstream because if you put something in your mouth and it's poison, your body has to know quick. No time for it to get to your stomach. So therefore, the mouth was connected directly to the bloodstream. However, in early humans, their mouths were closed most of the time because they were pre-verbal. Okay, they weren't like us, like blah, 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 blah. They were just hunting and gathering and mating, and you know, they weren't taking pictures of their food or putting bad reviews on Yelp or anything like that. So my theory is that the mouth is designed to be self-maintaining if it's closed most of the time, which is, I'm talking 22 out of 24 hours. That, of course, is impossible in modern life. And that, I think that's the basis of a lot of disease processes now, because we have a Maserati, but we're filling it with the wrong fuel and we're driving it completely contrary to what it was built for. So of course it's going to break down, right? But anyway, if we want to be taken seriously as healthcare providers, we need to know the names of medications. We need to know how to spell them. We need to know what conditions they treat. We need to know the names of medical conditions and medical terminology. It's really important if we want to be taken seriously as healthcare providers. So I took this off a Facebook group just yesterday, and it speaks very much to why I do what I do. And so this is somebody describing it, you know, an unpleasant interaction with a patient, and I'm dying because she was an old female. So I wonder how young this hygienist is. The old female is probably like my age. And, you know, so it was a bad experience for everybody involved, and a patient that comes in and acts like a wacko. Okay. So here's the thing. acts like a wacko is her opinion. We don't know what actually happened because there's no body cam. But what I take from these sorts of posts is that patient comes in, they're difficult, the provider makes a judgment and gets frustrated, and the whole thing ends badly for everybody. And my message to you tonight is it does not have to be that way. So no, we're not therapists, but neither are hairstylists, bartenders, or flight attendants, but we still have to deal with human behavior. The oral cavity is intimate. The oral cavity is sacred. The oral cavity, we should, it's like a chapel. It's not a construction zone. Look at the shape of that altar and look at the shape of the back of the throat. Okay. We should be entering as if we are walking into a church. Respectful. This is a whole lot of information right here. Feel free to screen share or take a picture, but this is an excellent description of what goes on in the brain and how the body responds when a person is in fight or flight. Excuse me. And fear affects people's perception. A frightened brain cannot process input the same as a brain that's not frightened. And fear and pain, fear makes pain worse. Fear affects patients' perceptions and it increases their pain. Fear creates distrust. I love this little meme over here about what we say and what they hear. And when a patient is fearful, when they're afraid, if they're confused, if they don't know what we're talking about to begin with, when they become afraid and anxious, they're going to distrust what we're saying, especially if we talk in a lot of jargon. What I love about our job is we get to touch people. And therapeutic touch is, I think, something that needs to be brought to the forefront for dental practitioners. When a person goes to their physician or whatever, they don't touch them very much. We get to touch people a lot. And therapeutic touch can be very powerful in bringing down an anxious patient. Just a little bit of light pressure. And you can do this while you're doing your orofacial exam. Just a little bit of light pressure. Just to kind of calm things down. So how do patients become traumatized? Well, the factors in creating trauma and anxiety, pain, suffocation, helplessness, shame, and also what makes it worse is the perception of an uncaring provider. So feeling, pain and suffocate, the lack of ability to breathe, these are things that are sometimes unavoidable during a procedure. But if the patient feels like we don't care, that's what reinforces the fear, reinforces the anxiety, and it drives that fight or flight response upwards. So, you have dental disease because your mouth is dirty and you are bad, even if that's not what we're saying. I don't think anybody actually says that, but because of their perception, and maybe somebody did say something like that, this is what they are hearing. Okay, the medical religious model of healthcare is still alive and well, where patient blaming, right? Disease is a punishment, and we blame the patient for their disease. And and health is the will of God. It's gone underground. It's in the background, but it's still there. So, judgment and prejudice. Am I forming an opinion without sufficient knowledge? How many times, oh my gosh, have I opened up a chart and seen all these notes by a former provider and been like, oh, great, this is going to be, this is going to be a circus. Or, and I've like made up my mind before I even open the door. What I try to do today is to not do that. And I've been doing a lot of substitute work lately, and people wanting to be helpful and wanting to help make my job easier will try to get me aside and give me the rundown on all these patients. And I pretty much just say, you know what, it's going to be fine. We'll just take it as it comes. Don't worry about it. We are going to be fine. So there's many factors that affect oral hygiene that create dental disease. We know the first one, mouth breathing, hyposalivation, dysbiosis, and acid reflux. And we know that mouth breathing contributes to all three of these things. Anne Guion has a wonderful course about saliva. And so saliva is magical. And this is where I came with my idea that when the mouth is closed, and humans are supposed to be obligate nasal breathers, but we're not anymore. When the mouth is closed, the saliva was flowing. It was flowing in and out of the crevices. It was going down in the sulcus. It was, doing what it does, regulating the pH, helping to, get the bacterial population in a state that's not so destructive. It's, not all the bacteria in the mouth is bad. There's really only a few of them that are particularly damaging, and they're the ones that are the hardiest. But when the mouth is closed and saliva flow is adequate, it becomes self-regulatory. I'd love to see a study on like monks or somebody that just right that has their mouth is silent, like test the bacteria.
I do have to say that I love Anne, by the way.
That what?
I love Anne. You have her name
Oh
on the
yes,
slide.
yeah. She's the
fantastic.
bomb.
Mhm.
She's the bomb. She's extremely knowledgeable and brilliant. So systemic acidosis is can be an initial event in the in causing dental caries. And we know, and systemic acidosis comes from mouth breathing. Respiratory acidosis starts with mouth breathing. So it's not just that the mouth is dry from not enough saliva. Mouth breathing disturbs the balance of the whole respiratory system, which is attached to your blood system, which is all out of balance. It's all connected. That is one thing that I'm very excited to see the dental profession coming around to, that this is all, the human body is one body. And, it's not just, we're not just working on these little white things to make them look pretty. So Dr. Tom Neighbors and Direct Diagnostics. So you can learn a lot from saliva screening. You can get a bacterial count and you can treat specific bacteria. I just subbed in a perio office that was using this. It was really cool. I'm reading the reports like, wow. And Barbara Tritz, of course, the queen of dental hygiene. She's all about, she talks a lot about this as well. And make note of these names. These are important names to know, besides mine, of course. So we want to prevent future trauma. I am a big fan of Dr. Chris Kammer. The American Academy of Oral Systemic Health has a lot of information on the things I'm discussing. Drop the drill. Dr. Chris Kammer treats decay without drilling. He says, when I go to the doctor with strep throat, they don't cut out my throat. They give me antibiotics and my throat gets better. And he uses silver diamine fluoride. Dr. Steve Duffin, of course, is the godfather of silver diamine fluoride. And, you know, when dentistry starts treating whole body health based in the oral cavity, with treating people's breathing as a part of that, and then approaching the treatment of periodontal disease from a perspective of chronic wound management. Why do we act like we're going to cure somebody? And that if they don't get cured, they did something wrong. Okay, this is a little exercise I did. This was a wound on my finger. And look how long it took. It took 10 days. More than 10 days, because the first picture is day 3. So if that took, and eventually it sealed all the way up. So that took 10 days. How do we expect an area that is constantly filled with bacteria, that never gets fully cleansed, to heal? Why are we expecting that we act as if that eventually people's gums are going to look like my healed finger? And you know, healthy gums look a lot like that, but there's still the 2 to 3 millimeter sulcus that's always there. So what exactly is happening in a periodontal pocket? So you got your biofilm, you got your periodontal pocket, and so the whole system gets screwed up. You know, part of healthy bone maintenance is the body has its little recon system, and it detects diseased bone and it breaks it down, and then it builds it back up. So you have osteoblasts and osteoclasts. In the presence of inflammation, that whole process gets messed up, and the osteoclasts are overacting. They're overproducing, and the osteoblasts can't keep up. And that's what's happening. You know, I'm really glad. It's nice to know you don't need to necessarily tell patients this, but the whole thing is biological. It's not mysterious. It's not, you know, it's really makes perfect sense in the scheme of biologics, of physiologics. So it's, you know, a wound is a disruption of the normal structure. Acute wound you expect to heal, but a chronic wound is one that's physiologically impaired. I've heard lecturers talk about your gum line is the size of your palm of your hand. But if somebody had, which is true, probably true, however, if you had a sore on the palm of your hand, you would know it. Okay, it would be painful. You would have loss of function. You probably might even be ill. You might have a fever, chills. So the problem with the mouth is that people can walk around with a mouth that's just as septic as that wound, but they have no idea. Non-traumatic instrumentation. I had a really nice visit with several dental hygiene students over the weekend about you know, this career and stuff, and I talked to them about instrumentation, you know, and showing them with the pen, because that's their thing. They're like, oh, calculus, I with the lingual of 2 and blah. I'm like, look, just relax, okay? And so instrument got to be sharp. My thing has always been less pressure, more strokes. With a light fulcrum, a very light fulcrum, I start at the margin and work downwards. And with an exploratory stroke, back and forth, back and forth. And then when I feel a deposit, I bear down and remove it. You know, and that's obviously you know, can be subject to change without notice. when you have a patient with a lot of super heavy tenacious calculus, which I've been experiencing quite a bit lately. And you know, it's very interesting what we do. All right, so oxidative stress and dyspnea. Airway trumps all. We know this. I am preaching to the choir. And I'm loving the choir, by the way. So oxidative stress and fear. In the book Breath, which I'm sure you've all read, Nestor talks about this patient. She had a dysfunctional amygdala, so she was incapable of feeling fear. And they tried to scare her with like everything, jumping out from around corners, pictures of ghosts, horrible things. And she was like, nah. But when they put something over her mouth, then she couldn't breathe, she panicked. That was the only time she was able to feel and display fear. So the feeling of not being able to breathe is extremely traumatic. So the body is going to survive. The brain is going to survive no matter what. And we compensate to protect our airway and to keep it open. And when patients come in to the dental office, they have these compensations too. And when they're in a position where they're feeling like they're going to be suffocated, they react with, physical, like protect, and the emotional response is anger, defensiveness. So the patient comes in and they display these behaviors, and we label we label their behavior, and then we approach them based on the label. And here's some of the labels we give them: gagger, sensitive, PETA, jumpy, touchy, demanding, bossy, jerk, and a new one, wacko, that I just got from that one thing in the beginning. In Surdentity, I broke down patient presenting archetypes. What I believe, and I still do, if you change the patient label, your approach will change. And I suggested, instead of, Mr. Jones is a jerk, Mr. Jones is fearful, presenting as hostile. Instead of Mrs. Jones is a wacko, Mrs. Jones is fearful, presenting as hysterical. How much do you want to bet the woman in that example had a list of medications this long, had a whole bunch of surgeries, and had all kinds of stress from her family, and nothing was her fault. She was always taking care of everybody else, and she felt very sorry for herself. So that's the classic hysterical patient. And fearful, presenting as controlling, as a clown, and submissive. So that's what I came up with to help people change their approach, change their mindset, so that they approach patients differently. It is my judgment of a patient that creates my suffering. It is not the patient. And the patient knows when we're judging them, and they're reacting to that, and they're just trying to manage their experience. Okay, this is why they don't touch that one, grab your hands. They make me feel dirty. I felt dirty. They make me feel like a bad parent. I'm a baby. I hate this. Just yesterday, a woman crying, shaking in my chair. And she said, I'm pretty tough otherwise. And to look at her, I'm like, yeah, I would want you on my side in a street fight. And she's like, but when it comes to this, I'm like, sweetheart, you are a product of your experience. We are gonna get through this. I also had a patient yesterday who chews tobacco, who knows that he's been told by countless people why it's bad for him. It's literally destroying his mouth. And I'm not ready. I'm not gonna stop. So you know what? I can educate, I can try and motivate, but I am powerless over other people's choices and other people's behavior. So the emotional experience of the appointment is what patients remember. We assess the interaction from our clinical aspect. Well, she had heavy super and subdigital calculus, profuse bleeding. We did a crown on number 3, I feathered the margin, blah, blah, blah. But patients don't understand or particularly care about our technical skills. They don't know good dentistry from bad dentistry. They know, did it hurt? How much did it cost? If a patient can't breathe, their emotional experience of the appointment will be negative. And it doesn't matter how luxurious or fun the surroundings are. Look at kids in these pediatric offices that are like Disneyland. They can't breathe. And kids today, and you all know this, and you're in the front lines of this, kids' airways now are smaller than ever. And and the dental cripple. So, and I see memes making fun of these sorts of people on dental groups, and it makes me very sad because these people, they've all been traumatized. They have toxic shame, and we need to get to the root cause of their disease before we do anything else. And this is where I think myofunctional therapists would be so beneficial in a dental office. Breath instruction. Oh my gosh, breath instruction, functional swallowing, dietary counseling. We could be doing so much more for these people than clean, and cleaning your teeth is good too, but we could be really helping these people to change their lives, to become something totally different. So mouth breathing and patient behaviors. So when patients come in and these behaviors that people complain about are all rooted in the inability to breathe, because these people are mouth breathers. They can't recline, sighing. So while you're cleaning your teeth, groaning. So they're sighing, but a lot of times that groaning is not on purpose. It's their tissues. It's like a little mini snore. So they're mouth breathing while you're trying to work in their mouth, and it's a groaning sound, but it's like a little mini snore. Throat clearing. Snorkeling was the best word I could think of. People that feel like they need to clear out their nose and like their entire pharynx and their upper respiratory cavity, and give you a sputum sample. It's pretty disgusting, but and I don't miss the spit bowl. Oh my gosh, I don't miss the spit bowl. But frequent closing, frequent rinsing, and frequent spitting, these are all behaviors that dental professionals complain about all the time. They are all rooted in mouth breathing. So, and patients have oral movements, reflexes that contribute to patient behavior. So we know this, right? They started out functional, but they become dysfunctional. And the tongue is weak, so other muscles are jumping in to compensate for it. And as my orofacial myofunctional therapist, this is what we are helping people to do. So, oral reflexes are necessary for survival in infancy, but they should integrate over time. Root, suckle, snout, gag, and bite. These are all these are not, you don't teach a baby how to do these things. They're reflexes. The transverse tongue goes to, so you touch over here, tongue goes over there. And the swallow, the tongue thrust swallow. And we know this, with the tongue thrust swallow, it starts with, bottle feeding, and, because it's protective. The tongue has to protect the airway because too much is going into the mouth and the tongue doesn't have to work to get what's going into the mouth, and there's too much. So it's just like, and you know this. When I was in Sandra Colson's course, Jennifer Tao spoke to us, and then the light bulb went on in my head about all this. And that's where I put the puzzle pieces together. So, we have reflexes, but we also have habitual muscle movements. They're not as strong as reflexes, but they're pretty strongly conditioned. And again, they're compensations. So the gag reflex, and that's what it is, people. It is a reflex. The tongue is going to protect your airway no matter what. Your tongue doesn't care. Your brain doesn't care. Your brain is going to breathe. The brain doesn't care how nice I am, what beautiful office I'm in, what freaking institute I went to or graduated from, or anything, or all the certificates on my wall. The brain doesn't care. The brain is going to breathe, and that is the bottom line. So if a person's a mouth breather and I put a bunch of stuff in their mouth, guess what? It's gonna go out. That's what gagging is. And I've learned to be more proactive in looking for signs of gagging in patients. And that they might not be indicated in the chart. And a lot of times I think it's the actual reason that patients refuse x-rays is because of the physical taking of the x-ray. Yeah, they say it's the money, the radiation, but it's really it's the physical x-ray in the mouth. So if you're looking at their previous x-rays, they have open between the arches, slanted occlusal lines, you can't get past the second molars, there's overlapping. These are all indicators that that the patient can't tolerate an x-ray in the back. And you know this too. So you look in there, they sit down, you look in there, you look, and they have tori, they have a scalloped tongue, they have a tongue tie, they have dry lips. These are all indicators that they probably don't like x-rays. And patients absolutely appreciate acknowledgement of x-ray difficulties. I have the patient, I look in their mouth, I'm like, oh, wow, you must hate x-rays. They're like, how did you know that? I said, I can see those bony protrusions in your mouth. Those are awful. Yeah. I had a 76-year-old woman who had a terrible gag reflex, and nobody was ever able to get bite wings on her, and I got bite wings. It was like so amazing. She cried. She cried. Roger Price, I want to talk a little bit more about that, but Roger Price talks about a pterygoid squeeze. So thumb and forefinger, and you just squeeze the pterygoid for about 30 seconds. But this is what works for me. So I have the patient breathe in and out of their nose for a full minute. Have them inhale through the nose. Hold their breath as they open their mouth. Place the sensor, and as I'm getting the image, they close. Okay, I want you to breathe out, push that air out, push it out, keep breathing out, keep breathing out. For some people, I will even put a little pressure on their philtrum right before I place the sensor. I want you to focus all your attention right here. Place the sensor. Okay, breathe out. And this 75-year-old woman, she opened, I'm like, okay, we got it. She said, what? I'm like, we got it. What? You got it? Yeah, look, it looks great. And she cried. She cried. Here she's 76 years old, been told her whole life, you're a bad dental patient. Maybe not in those words exactly, but that's how she felt. And that was a really wonderful, moment. So other reflex, and my nursing home experience is how I also came to realize about these reflexes when I was working with patients who were had severely compromised brain function. And I realized, wow, their brains are reverting back toward an infant stage. So these reflexes are coming back, or in a lot of people, they just never integrated. A surprising amount of regular people just walking around, their infant reflexes never integrated. So the snout reflex, this is, you have an overactive lips compensating for the tongue. These are the people that you have to really, they have heavy tartar, and when you're working, wait, I think I talked about this, yeah. So when you're working in the mouth, you have the patient close their teeth together, and you pull the lip down, and just keep having them close and pull the lip down, close, pull the lip down. And if you have to do it 100 times, just keep doing it. Eventually you're going to get the job done. And trying to tell the patient don't do that makes it worse. I tell the patient, I'm like, wow, your lip really wants to protect your airway. They're like, huh? I'm like, oh yeah, look at your lip. See how your lip curls up? It's just doing its job. It's just trying to protect your mouth, just trying to protect your airway. And that's what I say too about the tongue. Oh, tongue's doing its job. Tongue's just protecting your airway. It's doing a fine job. So overactive buccinators. I saw this a lot in the nursing home patients, people with dementia. The snout and the cheek tightening, I saw so much, and guess that's my husband and me. I saw this a lot in my dementia patients. Very difficult to get access. So the patient has to close their teeth together and use the mirror or an index finger to retract, and remind them to nasal breathe. Having the patient focus on nasal breathing during all of these things is very helpful. And this works well for everybody. I instruct my patients, begin brushing in the back, their mouth half open, and move the brush to the front. And when I show them, they're like, that can't possibly be cleaning my teeth, because they're using like a hard brush. I'm like, no, it really does, I promise. All right, so we know about this, right? The tongue thrust, low tongue swallow. And when we're working in the mouth, the patient, the tongue comes forward reflexively every time they swallow. So they perceive something in the back of the mouth, when the tongue comes forward. So these are, I see this meme a lot, and it's literally true. They can't swallow their own saliva, especially in a dental office where they have anxiety. So I use the saliva ejector. Why? I don't understand why hygienists complain about patients won't just use the saliva ejector. I was working in this one office, and I always, the other hygienists were always, giving me saliva ejectors. Oh, I never use it. I'm like, what? Oh yeah, you can take mine. I never use them. I'm like, how does that work? But anyway, so I work double-handed, and I use my saliva ejector almost continually in my left hand as retraction, as suction. And that's the technique I've developed. So fear creates anger. And again, we're not, we're not therapists, but we both deal with frightened people, and flight attendants have frightened drunk people. So at least we're not serving drinks in the waiting room. And if a patient comes in and they've been drinking, that's a red flag. Anger is a secondary emotion. And patients who are afraid and who become angry can act out. And these are just a couple of resources for situations which, God forbid, they should happen. But this is the world we live in, that people who are angry feel that they have the right to act out. So these were different resources for inappropriate behavior from patients. Dr. Ronnie Brown has a wonderful course about treating patients under the influence. Really, really good. And, it's something the office has to talk about and have a clear policy. When we're setting boundaries, okay, with patient, if a patient is being inappropriate, I can deal with up to a level, but if someone's being, cursing, using curse words, or, threatening, that sort of thing, you stop working. You make eye contact, a low voice, an even tone, and a neutral facial expression. And you don't apologize. You're making me uncomfortable right now with what you're saying. I need you to stop. And if they don't stop, then it's up to your discretion. Hopefully they do. But if they don't, nobody has to tolerate abuse. I'm all for I'm passionate about giving patients a good experience. But one time when I was living in Colorado, I gave this guy an injection, and he went down in the bathroom and punched the wall and yelled. I'm like, whatever, dude. That's just not appropriate. And if you have a situation where you've set your boundary and it's not working, you get out of there. You get space between yourself and that patient. You seek a safe spot. You tell the doctor, and you call 911 without hesitation. Do not hesitate. All right. So I've talked about a lot of stuff, talked about these patients, called out some of my fellow professionals, but here's the thing. So neuroception are the impulses that our brain gets that are below the level of consciousness. In the olfactory nerve and the auditory, the olfactory nerve is highly active in that fight or flight response. Your sense of sight doesn't when this whole trauma anxiety thing is going on, your sense of smell is the most powerful sense. So that's why people talk about the smell. I walk in and that smell. Back in the day, that smell used to be clove oil. I think dental offices in general smell better than they did. But so we have trauma too. Okay, and my trauma affects my interpretation of a patient's presenting behavior. I don't know about any of you, but I'm a wounded healer. I'm getting better, but I still am, right? I can care for other people, but I can't care for myself. Pouring out all this love and compassion and empathy for all these people, but the conversation between my ears is downright abusive. Before we can facilitate change in others, we need to first change ourselves. When I change, my world changes. And certainty comes from a lot of the information that I got from certainty came from me putting together the puzzle pieces of my journey toward wholeness and finding out things about myself and working through them. And I was just able to kind of take this and that and certainty. It doesn't mean I'm perfect. And it doesn't mean I'm like super serene every single day. Bob Barkley, the Inner Work and Co-Discovery, talks a lot about the same thing. There's a Bob Barkley workshop. There's a Bob Barkley study club. And inaspiritofcaring.com is another resource for learning about co-discovery and inner work for dental professionals. So, people pleasing, right? I need the approval of other people to feel good. I have difficulty saying no. What did I just say? Brutal self-criticism over mistakes, perfectionism, fear of authority figures, fear of conflict. These are all debilitating mindsets that create fear in me as a provider. And something interesting in that example I showed at the beginning, the hygienist said that they were terrified. So the patient came in angry and acting out, and it terrified this hygienist. So right off the bat, there was already stuff happening. What is fear? False evidence appearing real. Feelings are not facts. I love that. And how do we cope? How do we cope? Everybody has their ways, and maladaptive coping techniques can be destructive. I know for me, I quit drinking 25 years ago, and going into a dental office hungover and trying to deal with difficult patients was not fun. It's much easier when I'm not hungover. So these are all resources for you to evaluate yourself, just to take a look. And support groups. So I'm thinking more of these support groups where I see a lot of people ranting. Okay, I'm going to rant, I'm venting. And the thing is, describing the problem is not a solution. So are these groups, is it really support? So this person gets on there and, describes a problem, and everyone agrees with the problem, but nobody offers any kind of a solution. And making fun of patients is not a solution. It is never a solution to our frustration. Full stop. Think back to those pictures of the dental cripple. Those people are suffering. So this is a nice quote about patient-centered care from Avram King. And this is an ideal. This is something to strive for. This is certainly not like how I come in every single day. I'm like just this all the time, patient-centered, blah, blah, blah. My angel wings and such, my aura. But this is something to strive for. And we can, all I can do is strive. All I can do is try, right? Every single day. All right. Whew. So let's just all calm down for a second. I have some music here, and then I'll take some questions. In through the nose. Hold in for 5. Hold for 5. Out for 10. Oh, now it won't stop, for cripe's sakes. All right, well, I guess I'll just get out of it. There we go. All right, so we have reached the end of my little talk, and I didn't even look at the comments, but anybody have a question or a comment? I would love to hear it.
Oh,
Oh,
Beth,
but
you
it's
had
late
me-
though. I took the whole hour.
You had me rolling the entire time. I don't know about anybody else here, but if anybody saw my face, I was laughing. You had me rolling, but it was very interesting and I really enjoyed it. And you just add a comical relief to this. Okay. Dr. Michael Steinberg here says, how about when a 9-year-old kid is acting out in front of the mother that clearly has never disciplined that kid? Great
That
question.
is a tough one.
Hmm.
Very tough. And yes, I'm more upset with the mother. So for me, I have to really get that kid to focus on me. And, talk about the breathing, right? Okay, Johnny, I need you to look at me, buddy. Okay. All right. Sometimes, I can get a kid's cooperation because I'm good at saying goofy, what are you talking about, dude? What are you doing, man? Or I can imitate Disney characters and stuff. But so doing something to draw draw him in. But sometimes it's about just getting through and doing what we can do. And that's that's how it is sometimes. But I try to get the kid to focus on me and not look to the parent.
Yeah, that's right. And sometimes, gosh, those parents will just chime in and
Yeah,
it's tricky.
yeah.
It can be a very tricky and sticky situation. And sometimes I do ask the parents, would you mind just standing right out here where he can't or she can't, see you?
Yeah.
And maybe we can just have a little bit more of a communication here with just the two of us, but you still have access to viewing us. But as long as, Susie Q doesn't see you, then maybe there might be a little bit of different interaction or something.
Yeah.
Now it doesn't always work out that way, but
we are human.
Worth a try. That's right.
We are human.
Yeah. It writes back. Thank you so much. You're a hoot. Marvelous is what he says. Anne says, as a non-dental professional, this was enlightening. Thank you. Anne
You're
is
welcome.
Our marvelous speech and language pathologist on Airway Circle. And she is something very, very special to all of us. So that was great. We did.
Awesome.
Yeah, we had a couple of comments on when you were talking about gagging. There were some recommendations that were put here and in the chat box. So I don't know if everybody has seen them, but someone uses a packet of salt, sprinkle some on the tongue.
I've heard that.
Okay, yep, that works about 95% of the time.
Yeah,
Mhm.
unless they have high blood pressure. I had an issue with that one time.
Ooh, good point.
Yeah, so then I started asking every time, do you have high blood pressure? Okay, well,
Right,
I'm
right.
gonna do this. And it is easy. It works every time.
Yeah,
And I
yeah.
used to explain to my patients, they would be like, why did that work? And I would tell them, whenever you have something that doesn't belong in your mouth, like an x-ray or, all that stuff,
Mhm.
your brain know it doesn't belong in there. But whenever you don't gag like that on food, and sometimes you take a big bite, bigger than the x-ray, you
Mhm.
know?
Right.
Yeah.
So if your brain knows it's food, so we're tricking your brain whenever you put salt. It's telling you it's okay,
Mhm.
whatever it's coming in, it's okay. So go ahead and yeah, they accept it pretty well. But that's
Yeah.
awesome.
So, also, I'll throw this in there too,
Okay.
real quick, is that how sometimes the sensors are just a little bit, a lot of bit thicker.
Oh,
When you
yeah.
have the sensor and you just have the bite wing or anything on there, I always let the patients who I know are gaggers, I let them lick it first so that their tongue can see what it feels like before I go ahead and place it really into the mouth itself. Okay, so you see this right here, this is what your tongue is going to be feeling, and this is the bump, and this is it, and okay, bam, bam, in. But then again, I don't have to walk out. Some offices still have that you have to walk around the corner to push the button.
Mhm.
We use the Nomad, bing, bang, boom, it's
Yep.
done.
Yeah.
That's the
Oh, yeah.
convenience
I
of
love the
having
Nomad.
that. Yes, yes. I know that we do have a question. Renata, did you have a question?
Yes.
Okay.
I have one, but Dana Moon said, "Hi, Beth," and she
Hi,
says,
Dana.
I asked the parents to leave the room. LOL. They
Ah,
and then they behave much better. I remember cleaning one time a 2-year-old. I used to work in a pediatric office, and this 2-year-old little boy was doing so good, and the mom was sitting in the corner in the chair. All of a sudden, the mom stands up and goes like this on his leg. He out freaked out. And I mean, if you think about in a child's mind, my
Yeah.
mom just saw something that I didn't. Something's about to happen because she came over here to comfort me, and everything was going fine. So I asked her, "You're welcome to stay right at the door, but you need to stay outside the door. You can stay right there. You can see, hear everything that's going on." But sometimes, yes, kids will do better without the parents. But we all know that, you know, I'm a helicopter parent, so
Mhm.
I can't say, well, sometimes I think that I go through, but anyways,
Right, right.
we hear stories of offices not being nice to kids. I've seen and I've experienced people not being nice to children in dental offices. So it
Right.
is, we all get it. We all understand. There's a question over here. I don't think that you touched specifically on this, but it says, what shift within the airway space do you hope to see that would align with certain, how do you say the name of your book?
Is it in the chat?
Yeah, no,
Okay.
it was one of Anne's question. Yeah, let me see if I can.
Certainty.
Yes, I
Oh,
can't say it.
oh, certainty. Say the question again.
Yeah, let me copy it and I'll paste it on the chat. Make sure it's not Angela only. There it is. What shift within the airway space do you hope to see that would align with your book?
Oh, well, I would put all the information I just presented to you in the
Okay.
book. And because when I wrote that book in 2013, I hadn't been educated yet.
Wow.
And I had been a hygienist for some time. So that's where I came up with the archetypes of the presenting behaviors, and I knew the emotional experience was what mattered. But it wasn't until I took that initial OMT course that I put together. Oh, it's their airway.
Mm-hmm. Absolutely. Well, today has been a lovely, lovely night. I really enjoyed listening to so much hygiene. I miss it so much. So this was a great reminder of why most of us, went into this profession over here. Lori said, "I remember we met at a dental conference shortly after you published your book."
Yes, that's right.
But I do want to, before we go, tell everybody the girls and I are having a huge meeting, and some good and amazing changes are coming to Airway next year to Airway Circle. But one of the cool things that we have going on is our mentorship program. We all know that there's no standardized education in the airway myofunctional therapy field. And a lot of us don't have that, what we have in hygiene, that we get all this education and then we practice, you know, and we watch other people and they watch us and we have that guidance. So we did put this mentorship plan together, a program together. It's about 2 months long. We have over 20 hours of content. We kind of go, you know, a little bit into the basics of myo. We talk about muscles and all of that stuff. And then there's several lessons that you're able to watch us work. So we're doing consultations, we're doing full assessments, we're doing therapy sessions.
Excellent.
And then the biggest
So
thing
important.
of them all, well, Angela and Tamara do share pointers of the consultation. She goes through her whole consult and talks about each individual thing. What are you supposed to be looking at whenever you ask this? So the big thing about this is that we are going to share, one, the assessment that I put together after looking at like almost 15 assessments from all over the world. I had some in Spanish, I had some in Portuguese, I had tons of English ones, and I kind of gathered what I thought were the most important things, and I put in one, and I'm going to be sharing that with the world, with everybody. We're going to share that on November. What day is it, girls? 22nd?
Is it the 22nd? Tuesday? It's in 2 weeks. So yeah.
Okay. Wow. So exciting.
Yes, November 22nd. Everybody meets us at 8 p.m. Eastern. I'm going to be sharing that with the world. So anybody who would like to use that assessment, you guys are welcome to. If you think about it, and I would love any input. You know, if somebody says, Renata, I don't think that's very valid, or Renata, let's add this because it is super important and it needs to be in there. So that's a meeting for us to all kind of share what we have seen and what we think that it works. Because how incredible would it be for us to have a more universal, in, you know, quotations, more universal assessment where we could, you know, send a referral to a provider and they kind of would already, you know, expect what to see. Or if we're communicating with another myofunctional therapist, you know, plenty of times we're, you know, referring patients to each other. How cool would it be for us to have something very similar? And the way that I have the assessment, you don't have to do everything. So if you have a 4-year-old and you're looking at TMJ, or, you know, you don't have to answer that, or you can't see the occlusion at all. If you cannot see the occlusion all the way in the back, you're not going to write class 1. You know, you're not going to write anything at all because you couldn't see it. So things like that you can skip and it's not going to show in your report. So that's one. We're going to be sharing the assessment. And the second big thing, I'm going to get my bag of tools that I sent to all my patients, and I'm going to go one by one tool that I have, and I'm going to tell you guys, what do I use it for, how I use it, so which exercises I'm doing with each tool, and how, you know, why would I prescribe that to a patient. And one thing that I'm going to leave everybody with, most of us prescribe the exercises wrong when it comes to muscle physiology. We're not giving it correctly, the prescription of the exercises. So I'll be talking about that, how to properly prescribe whenever you're looking at muscle. So I hope to see everybody there. It starts January 1st. We have a wait list right now. It's going to be a small group because everybody who participates in Myo Circle, you guys are going to bring one patient over to us. You do the assessment that we gave you the template for, and then you bring it into the group, and everybody, we're all going to look at the patient. We're all going to assess together, and we're all going to treatment plan together. So we're really going to push that critical thinking. Okay, what do you see here? What do we have to work on? Because so many people will give exercises that we are so used to because it's on a list and we kind of have to use. And I mean, you know, all of us go through this at points that we really didn't know what to do, and you just give them something to do something because you know it's not going to hurt them, you know. So this program, it's more like, okay, let's really think about this, because that's going to shorten the time that you're going to do therapy.
Mhm.
Because if a person can do, whenever you ask them to do a side to side and they can do it, why are you going to give them that exercise?
Mhm.
Why are you going to waste a week or 2 weeks of them doing something they
Mhm.
can do perfectly? So you really have to get good at the assessment. That's why I have the assessment the way that I have, for you to be able to see exactly what's working, exactly what is not working. And we can target therapy and target treatment plan exactly to that patient. So we're going to have some special guests over there, which is the Airway Circle board. And we're going to have some surprises, but super excited to see who our first class is going to be. Starts again January 1st, but we have a wait list. We're going to open up the sale, the cart, well, maybe it's going to be a weekend, but it's going to open up on November 25th. Is that right, girls?
Yes.
November 25th. That's the day after Thanksgiving. Is that Black Friday?
Yeah, I think it is.
Okay. So on Black Friday, we're going to open up. The first people that sign up are the ones that sign up. Everybody's going to get an email, and then it's closed. And we might do that once or twice a year. I'm not sure yet if we're going to have time to do it twice. But it's going to be a fantastic course. We're talking about muscles, cranial nerves, exercise physiology, and a bunch of cool stuff that I think you guys are really gonna like. And this whole group that comes with us, we're gonna automatically put them on Circle Time. Circle Time is our study club for myofunctional therapy, because I feel like that's how we learn as myofunctional therapists as a group, by sharing experience and sharing cases. So we got to keep that going somehow. And by the way, Circle Time is going to be quarterly next year, because we're going to have some really good meetings, really meaningful, intentional meetings. So we're going to reduce it to quarterly so we can do that for everybody, and we can focus on other courses. Any questions? Does anybody have anything to share? I know I talked a lot tonight and I wasn't supposed to even show.
It was perfect. And don't forget everyone to sign up for Elfster. It should be in your newsletter for those who are members. And if not, I will go ahead and post that here as well. There you go. If you haven't heard of Elfster, just click on the link and then you'll be able to read about it, because I know that we want to respect Beth's time as well. I know we've gone over a bit here. Gosh, what else?
All right, that is it. We have okay, we have Elfster instead of book club. And next week, who do we have next week?
Oh,
Dr. That really good looking guy.
yes.
Oh, is it the favor?
I think so. Is that right, Angela?
Yes, that's correct.
Okay, we have tried to have Dr. Faber. Guys, he is huge in the orthodontic world. Huge.
Wait, who is it? Because you also have is it?
He's an orthodontist.
Yeah, I'm thinking that's this guy from Toronto that you have coming up too. No, Kurt.
Yeah,
your Brazilian friend.
Karen's so handsome.
Oh my God. If he was my dentist, I would be eating cake frosting. Okay. I would just be eating it out of the thing. Oh, I have another cavity. You're kidding. Oh my God.
So funny, because my mom said the same thing whenever I posted the video of Karen. She goes, "Oh my goodness, who is that?"
Yeah,
he is, but he teaches us. He has an expansion project. I think it's sold out now, but it's going to be in January. He has another one, I think, in April. But he teaches dentists how to become very profitable and how to kind of like go next level personal and sales, and how to rearrange your business to be successful. So it's called the Expansion Project. It's in Mexico. You stay in this beautiful villa, and he has a bunch of activities we're gonna do. So I'm gonna share with you guys whenever I'm there. I'm super excited for it, and it's a great environment to be in with different professionals. But anyways, yeah, this Anton too. That's Sunday. That's what it is. Business series is this Sunday.
That's right.
So we have Karen, we have Renee, and it's all about business, because we all know, most dental hygienists are not business owners.
No.
Very few of us know exactly how to run a business and how to be profitable. So I want to add that, Airway Circle, I want to be like all around. Let's try to look at everything. So we're going to be investing a little bit more next year into personal growth and business growth. And these two courses, one in November, one in December, are all about that. So super excited. If you're a Launch Your Inner Myo member, a Myo Circle member, or a Golden Circle member, you get these for free. These are included in whatever you paid. If you're a regular Airway Circle member, then you have to pay, I think it's $49 only, but it's 3 lectures, 30 minutes each, and it's going to be fantastic. So
I
I
just
hope to see
posted
you.
that link.
Thank you so much. And I'll go ahead and put this webinar into our Kajabi tonight. And if anybody here has any trouble accessing Kajabi and looking at the past webinars we have had, please just let me know and I'll do a little tutorial. Thank you guys so much. Have a wonderful night. Thank you, Elizabeth.
Yes, thank
you.
you.
Were fantastic. All right. I'll
Thank
see you
you.
guys next time. Bye.
All right. We'll see you
Bye.
next time. Bye-bye, everybody.